Hello, the topic of this video is radiopharmaceuticals. I'm going to start in this first video talking about some of the most commonly used radiopharmaceuticals for therapy, and then we'll get into a brief discussion about release criterion of patients in the second part, and then we'll go over a detailed calculation of dosimetry from radiopharmaceuticals. Here we go. We're going to start with three common types of radiopharmaceuticals as clinical examples. So let's start with iodine-131. First, it's made in a reactor, and let's recall quickly the decay scheme. Here it is. So we have I-131 decaying into xenon via abated decay. So the xenon then decays into its ground state, releasing gamma rays, and those can be used for imaging. And the therapy comes from the beta particles that are emitted. The maximum energy is 600 keV, but it turns out the average energy is 192 keV, and the range of that beta particle is about 1 millimeter in tissue, so localized. The iodine is delivered as a sodium iodide compound that goes to the thyroid. So you can think of it as one of the earliest examples of ablative therapy. It's used against thyroid cancer, hypothyroidism. And here are some of the injected activities shown here. So for a postoperative case, it might be 750 to 150 millicuries, nodal disease 150 to 200, and then metastases would be 200 millicuries or more than 200 millicuries. After delivery, about 30% of the delivered dose is trapped in the thyroid, and the rest is cleared through the urine. And you can do an initial imaging study with a tracer amount of the compound to see what the uptake is. Here's what this looks like. So a reactive iodine uptake test, you typically would use a small microcurie amount of compound and image it. When you administer for therapy, it goes either through an oral solution or a gel tablet, and shielding and protection of the patient and the staff is important. So let's move on to the next radiopharmaceutical, yttrium-90. It's a byproduct of uranium in a reactor, and it again decays by beta-minus decay with a short half-life, 2.7 days. And these beta particles have a somewhat longer range in tissue, but it's still very localized. The indications for this type of radiopharmaceutical are liver metastases and unresectable hepatic cellular carcinoma. It goes through intra-arterial injection, and that preferentially targets the tumor. And the reason for that is that normal liver, about 80% of the blood supply comes from a vein, but in a tumor, about 80% comes from artery. And so by injecting intra-arterially, you can get a preferential dose to the tumor. This formulation is typically through glass bead microspheres, which are 20 to 30 microns, and they embolize in small vessels in the tumor. So to deliver this therapy safely and effectively, you really have to account for the biodistribution of this compound, and so I'd like to describe that for a moment. You start by taking images with a technetium-99 microaggregated albumin. That's a surrogate for the biodistribution of these microspheres. Here's the type of image that you get, a SPECT image, and it's achieved via an intraarterial injection, and that's just like you do with the therapy. And then you measure the lung shunt from the SPECT images. So you measure the counts from the lung divided by the counts in the lung plus the counts in the liver. If this lung shunt is more than 20% or 126 millicuries, it's a contraindication for this type of therapy. And overall, the goal is to keep the dose less than 30 gray to 1 kilogram of lung. So now let's look at the final therapy. This is radium-223. That radium comes from an actinium generator, or a cow it's called. And the actinium is produced from a activation of radium-226 in a reactor. The half-life is 11 days, and it emits a short-range alpha particle. So this radium chloride formulation is used to treat prostate metastases that are resistant to hormone ablation therapy. And this is to bone only. And the reason for that is that the mechanism is that it's chemically similar to calcium, which means that it's absorbed into new bone stroma. The alpha particles that are emitted are short range. They're less than 100 microns. So they're attractive relative to strontium-89, where the beta particles have a longer range. This was FDA approved for this indication in 2013, and a typical injection would be as written here, 1.3 microcuries per kilogram, goes IV 6 times with 4-week intervals. And here's the trade name. This type of radiopharmaceutical is an alternative to other type of isotopes that have been used in the past. And here's some of the evidence for this, looking at an increase in median overall survival in the cohort that received the therapy versus those that did not. All right, so now we're going to talk about some of the safety aspects of this. We're going to talk about regulations from the U.S. perspective. And then we're going to talk about criteria around releasing patients from the hospital who have received radionuclide therapy. In the U.S., it's the Nuclear Regulatory Commission, the NRC, that oversees the use of isotopes that are produced in nuclear reactors. This is codified in the Code of Federal Regulations, CFR, and here's a citation, which is important, 10 CFR 35 for the medical use of byproducts. Certain states in the U.S. are agreement states, it's called, which means that they agree to administer the rules for the NRC and oversee that. Here are some key concepts. So there's an authorized user, and that's shown in this part, which has to fulfill specific criteria. You need a written directive for the therapy. You need an independent determination of the source strength, and you have to follow these rules for releasing the patient back into the community. The rules for releasing patients depends on which isotope you're talking about. So let's look here first at I-131. So you'll see 2 levels here. First, below 7 millicuries, you can release the patient without any instructions. If it's a little bit higher but still less than 33 millicuries and the survey is less than 7 millirem per hour at 1 meter, then you can release the patient, but you have to have special instructions. Now, at higher doses, there are other criteria. Larger doses require a patient-specific calculation and instructions to the patient. If any member of the public is going to receive more than 5 millisieverts, then the patient has to remain in the hospital. And finally, release is permitted if the oral dose is less than the number quoted here, or the survey at 1 meter reads less than 48.5 millirem per hour. So obviously this gets fairly complicated, and there are many rules, many different isotopes. I've shown you just one of the important ones. All right, there are more radiopharmaceuticals out there and more being developed every year. But I hope this gives you a basic flavor for how things work. So let me leave you with this list of reading materials. It's quite long because there's quite a bit of information out there about these things, and I think it may be useful for you to dig into some of these. All right, I will see you in the next video.